Hello everyone, it is Dr. Locklear here, and I'm coming to you today to talk about the concept of metabolism as it relates to Exemplar 12A, and this is type 1 diabetes mellitus, or T1D, as you will see in your reading. This is a very lengthy chapter. All the information that I cover is very important. I advise you to read this chapter thoroughly and read it numerous times because most of the information in here is very, very important. Diabetes is a disease that affects people of all ages. You as a nurse will constantly have diabetic patients, and you need to know how to educate them on how to give themselves their injections, monitor for hyper and hypoglycemia, how to read a syringe, educate them on the different types of insulins, diet, exercise, and psychosocial, because this disease doesn't go away. There's no cure, and psychosocially, people have a struggle dealing with diabetes because they have to watch everything they eat. It is a component of their daily life. So let's get started. Let's look at our objectives, our learning outcomes. So what is the patho of type 1 diabetes? There's type 1 and type 2. And we will talk about both of those. Type 2 is Exemplar 12B, and that chapter is nowhere near as long as this one. What is the cause of type 1 diabetes? What are the risk factors and how can we prevent it? What do you see from the clinical standpoint when you do your assessment? How does a diabetic patient look? How do you know when they're experiencing elevated blood sugar, which is hyperglycemia, compared to low blood sugar, which is hypoglycemia? You're going to look at the complications of type 1 diabetes. What can happen to a person's body? Diabetes affects all organs and all functions of the body, from the skin to the heart to the liver to the circulatory system, your kidneys. It affects so many things, even your ovaries. You can have issues with hormones with diabetes. We're going to look at the diagnostic test and the therapies used by the interprofessional and interdisciplinary team. How do we collaborate care? You will be working with these patients in the facilities, and they have to go home and manage their own diabetes. How do we differentiate care of patients with diabetes across the lifespan? Again, I said this is a disease that affects any age group. Can you imagine being 10 years old and you can't have an ice cream like everybody else? You're different and you feel different. And children are very impressionable, so this disease really plays on their emotional status. We're going to look at the nursing process. What do we see when we observe? What do we ask when we interview a patient? What are we specifically looking at the head-to-toe assessment? What are our pertinent nursing diagnoses? Which one has the highest priority? Many things that we will use the nursing process for these patients. I have a YouTube video here that you can watch on type 1 diabetes, and if we have time, I will show it in class, but please watch it before you come to class. So what is our overview? Diabetes is often referred to simply as diabetes or DM, or type 1 or type 2. It is a disorder of hyperglycemia, which means elevated blood sugar, resulting from defects in insulin secretion, insulin action, or both, and it leads to abnormalities with your carbohydrate, protein, and fat metabolism. According to the American Diabetes Association, or the ADA, there are 4 major types of diabetes. Type 1, and this is 5% of the diagnosed cases. Type 2 is 95%. Gestational diabetes, and this happens during pregnancy, or any other specific types of diabetes. So with type 1, basically what happens is the pancreas which is where insulin is made in the islet of Langerhans or Langerhans. You can pronounce it either way, and you will hear that, the islets of Langerhans. There's not enough insulin produced in type 1. In type 2, you can produce insulin, but it can't get into the cells for the cells to use it for energy. So there are two different situations with diabetes. So this chapter again focuses on type 1 diabetes. So what are the role of hormones? The pancreas produces hormones necessary for metabolism. So we know metabolism is the breaking down. It uses our food and our carbohydrates and our proteins and our fats to give us energy, okay? So it's the breakdown or metabolism and cellular utilization of carbs, proteins, and fats. And we need all of these for energy and for muscle growth and to help our immune system stay intact. We need all of these components here. The cells that produce these hormones are located in the islets of Langerhans, and that is in your pancreas. So the alpha cells and beta cells and delta cells, they all have a specific purpose. So the alpha cells produce the hormone glucagon, which stimulates the breakdown of glycogen in the liver, the formation of carbohydrates in the liver, and the breakdown of lipids, which are fats, in both the liver and the adipose tissue. And adipose tissue is basically our fat tissue on our body. The primary function of glucagon is to decrease glucose oxidation and to increase blood glucose levels. Through glycogenolysis, or the breakdown of liver glycogen, and glucogenesis, the formation of glucose from fats and proteins, glucagon prevents blood glucose from decreasing below a certain level when the body is fasting or between meals. So in other words, it keeps our sugar at a normal level so we don't feel the effects of it. If any of you are diabetics, you know what I'm talking about. If your blood sugar is too low, hypoglycemic, you feel very weak and confused and no energy. If your blood sugar's high, you may feel sweaty and hot. And so here's something I want you to remember. If your blood sugar is low, hypoglycemia, remember this: cool and clammy, I need some candy. I need something to get my blood sugar up. My blood sugar is too low. If I have hyperglycemia, then hot and dry, sugar too high. So if I feel hot and flushed and dry, then my sugar's too high and I need to get something to get it down. Just something for you to easily to remember that with. The action of glucagon is initiated in most individuals when the blood glucose falls below 70. So somewhere between around 70 to 100 or 110 is usually the normal range of blood sugar readings. Anything below 70 or above that 100 mark, some places even say 70 to 90, some say 70 to 100, and some say 70 to 110. As you'll see as we go along, you will see some readings that will tell you what determines if you may be a diabetic, and we'll get to that. Beta cells secrete the hormone insulin, which facilitates the movement of glucose across cell membranes into the cells, and it decreases blood glucose levels. So insulin is going to help process the glucose that we have. It helps break it down, helps us use it as energy, and it helps keep our sugar level from being too high. That's why we need insulin. Insulin prevents the excessive breakdown of glycogen in the liver and in muscles. It facilitates the formation of lipid while inhibiting the breakdown of stored fats and helps to move amino acids into cells for protein synthesis, because our cells have to have something to give them energy. After secretion by the beta cells, insulin enters the portal circulation travels directly to the liver, and is then released into the general circulation. Circulating insulin is rapidly bound to receptor sites on peripheral tissues, usually muscle and fat cells, or is destroyed by the liver or kidneys. Insulin release is regulated by blood glucose levels. It increases when blood glucose levels increase, and it decreases when blood glucose levels decrease. When an individual eats food, insulin begins to rise in minutes. It will peak in 30 to 60 minutes and then return to baseline in 2 to 3 hours. So in other words, when you eat something, your glucose levels will go up even if you're not a diabetic. But this process of these alpha cells and beta cells and delta cells are going to kick in, and they're going to say, hey, your sugar's too high, and we're going to do our job. We're going to move this sugar into the cells where it can be broken down and synthesized for energy, and that's going to keep our sugar levels or our glucose levels from being too high. And I'll try to explain this in as easy a terms as I can to help you understand. Delta cells produce somatostatin, which is believed to be a neurotransmitter that inhibits the production of both glucagon and insulin. So with these delta cells, they help balance as well. So what is blood glucose homeostasis? So when we have homeostasis, we want the blood glucose to be in that normal range where we don't feel it's too low or too high. The higher your sugar, the more damage it does to your organs. So we want to keep it in a normal range. All body tissues and organs require a constant supply of glucose because that gives us energy. Not all tissues require insulin for glucose uptake. The brain, liver, intestines, your renal tubules do not require insulin to transfer glucose into their cells. Skeletal muscles, cardiac muscle, and adipose tissue require insulin for glucose movement into the cells. Normal blood glucose is maintained in healthy individuals through actions of insulin and glucagon, as we said before. Increased blood glucose levels, amino acids and fatty acids stimulate pancreatic beta cells to produce insulin. So as the glucose levels rise, these beta cells will be triggered to produce more insulin to help counter the rising glucose levels. As the cells of cardiac muscle, skeletal muscle, and adipose tissue take up glucose, the resulting decrease in plasma levels of nutrients suppress the stimulus to produce insulin. If blood glucose falls, glucagon is released to raise hepatic glucose output, which raises glucose levels. Epinephrine growth hormone, T4, which is a thyroid hormone, and glucocorticoids, often referred to as glucose counter-regulatory hormones, also stimulate an increase in glucose in times of hypoglycemia, which is low blood sugar, stress, growth, or other increased metabolic demands. The regulation of blood glucose levels can be seen illustrated here on page in figure 12.4. I'm sorry, excuse me. And so you will see on page 809 how this works. I know that's a lot to uptake on the very first page of this chapter, but just know that when the blood sugar gets too high, your body's going to make more insulin. When it gets too low, it's going to decrease making insulin so it can maintain that balance. When you eat, your sugar goes up, especially if you eat high carbs and fats and high sugars and things, it'll go up. That's pretty normal. But your body kicks in to counteract that. When you're a diabetic, you have alterations in these mechanisms, and your body does it. Sometimes it makes too much insulin, and so you may be hypoglycemic, or sometimes it doesn't make enough and your blood sugar levels stay high because there's not enough insulin to provide that homeostasis. I hope that makes sense. So what's the patho? The destruction of the beta cells of the islets of Langerhans in the pancreas, the only cells in the body that make insulin, is the cause of type 1 diabetes. When beta cells are destroyed, insulin is no longer produced. So again, these beta cells in the islets of Langerhans are the only thing in our body that makes insulin. So when you're not making insulin, your glucose levels are going to be up, especially if you're not eating correctly, and you're going to have to take some insulin by injection to counteract the elevated glucose levels. When beta cells are destroyed, again, insulin is no longer produced. Although type 1 diabetes may be classified as either autoimmune or an idiopathic disorder, 90% of the cases are immune related. The disorder begins with insulinitis, which is a chronic inflammatory process that occurs in response to autoimmune destruction of the islets of Langerhans. So in other words, autoimmune means the body's attacking itself for some reason. So something attacks these beta cells in the islets of Langerhans and it destroys them. And they don't know what triggers that process. A lot of people that have thyroid issues or other issues with their endocrine glands or their hormones will end up being diabetic. This process, which slowly destroys beta cell production of insulin, usually occurs over a long period of time, with the onset of hyperglycemia occurring when 80 to 90% of the beta cell function is lost. So it takes a long time. Children who have type 1 diabetes have usually there's a genetic issue or a congenital abnormality in the pancreas that causes that. And this is a genetic disorder. You can inherit this disorder. Researchers believe that both alpha and beta cell functions are abnormal, with a lack of insulin and a relative excess of glucagon resulting in hyperglycemia. So what are the causes? The onset of type 1 most often occurs in childhood and adolescence, but it can occur at any age, even in your later age of life. The actual cause and exact sequence is not really understood. Genetics play a role. Again, this is a genetic disorder. It can also be triggered by viral infections such as mumps, rubella, Coxsackie virus, chemical toxins that are found in smoke and cured meats. It's a result of response occurs in which antibodies respond to normal islet beta cells as though they were foreign. So when these autoimmune disorders, like I said, it looks at these cells as foreign and it kills them. It starts to break them down and they really don't know why. And here are your risk factors: 1 in 400 to 1 in 1,000, and 1 in 20 and 1 in 50 in children. That's a lot. There's a lot of diabetics in this world. Prevention: there's no way to prevent type 1 diabetes. They're working to fully understand what causes it. If they had a better understanding of the patho and triggers, they could find a way to hopefully find a cure or a prevention to even stop it. So what are the clinical manifestations? You see hyperglycemia, which is elevated blood glucose levels, a breakdown of body fats and proteins, and development of ketosis, which is an accumulation of ketone bodies produced during oxidation of fatty acids. So, well, we're going to talk a little bit more about that, but when you have diabetic ketoacidosis, the body's breaking down fat to get energy. As the manifestations appear, approximately 90% of the beta cells are destroyed. Manifestations may appear at any time during the loss of the beta cells. If an acute illness or stress increases the demand for insulin, beyond the reserves of those damaged cells. The chemical manifestations are from a lack of insulin to transport glucose across the cell membrane into the cell. The accumulation of glucose molecules in the circulating blood results in hyperglycemia. Hyperglycemia causes serum hyperosmolality, drawing water from the intracellular spaces into the general circulation. So it's pulling water out of the cells. The increased blood volume increases renal blood flow, and the hyperglycemia acts as an osmotic diuretic. The result is increased urine output, polyuria, and you need to know that term. So increased urine output. When the blood glucose level exceeds the renal threshold for glucose, which is usually 180 milligrams per deciliter, glucose is excreted in the urine, glucosuria. So you will see it in the urine as well. The decrease in intracellular volume and the increased urinary output cause dehydration. So your mouth becomes dry, you get very thirsty, and so the person starts to drink a lot. And so now you have polydipsia. The blood glucose cannot enter the cells without insulin. So you got to have that insulin to get it into cells. It's the transporter. It transports it into the cells. So you have decreased energy production. This decrease in energy stimulates hunger, because if I get hungry, I can get in nutrients to help give me some energy. And diabetics want to eat all the time, and they're often overweight. This causes the individual to eat more, polyphagia. Despite increased food intake, the individual loses weight as the body loses water and breaks down proteins and fats in an attempt to restore energy sources. Malaise, which is fatigue and tiredness, accompany the decrease in energy. Blurred vision occurs, resulting from osmotic effects that cause the lenses of the eye to swell. The classic manifestations of type 1 are polyuria, polydipsia, and polyphagia, the 3 P's. I want you to remember that, the 3 P's, 3 P's. Polydipsia, polyphagia, and polyuria. You also have weight loss, malaise, fatigue. Depending on the degree of insulin deficiency, the manifestations vary from slight to severe. Some people become comatose. They feel very weak and they pass out. With type 1, you require exogenous insulin. So this is insulin from an outside source. So in other words, you're going to have to start taking insulin shots. And a lot of people don't want to do that. I have type 2 diabetes, and I take a shot once a week. I take Ozempic, and hopefully I can bring one of my insulin pen. It's not an insulin, it's a hormone regulator, but I can show you how to use one of the pens. It's very neat how it comes in the kit. What are the complications? Before we go to that, I want to make sure that when you're reading this chapter, and again, I can't stress enough to read this chapter thoroughly several times, because diabetes is one of the biggest diseases that nurses work with. But look at the clinical manifestations and therapies listed on page 810 and on page 811, the multi-system effects of diabetes. And you can see how it affects the neuro and the sensory and the cardiovascular and the renal. And it gives you all of the side effects you'll see from that. And we're going to talk about those as well. So complications, alterations in blood glucose levels, alterations in the cardiovascular system, neuropathies, a lot of affects the circulatory system, and so a lot of people have pain in their lower extremities from the neuropathy. They call it neuropathic diabetic leg pain. In addition, the interaction of several complications can cause problems in the feet. It shows the progression from cardinal signs to acute and late complications. You can get sores on your feet that can become gangrene and have to have your foot amputated, or toes, or below your knee, Once you get gangrene, it's too late. So what are the acute complications? What do we see with these? Um, in the hyperglycemia. I'm sorry, I just lost my train of thought. Hyperglycemia. So hyperglycemia is elevated blood sugar. So you experience something called the Doan phenomenon and the Somogyi phenomenon and diabetic ketoacidosis. And we're going to look at all of these. The Doan phenomenon is a rise in blood glucose between 4 a.m. and 8 a.m. that is not a response to hypoglycemia. This condition occurs in individuals with both type 1 and type 2. They don't know what causes it, but it is believed to relate to nocturnal increase in growth hormone, which decreases peripheral uptake of glucose. So when you get up in the morning and check your blood sugar, it may be a little elevated. The Somogyi phenomenon is a combination of hypoglycemia during the night with a rebound morning rise in blood glucose to hyperglycemia. The hyperglycemia stimulates the counter-regulatory hormones, which in turn stimulates glucogenesis and glucogenolysis and inhibits peripheral glucose use. This process may cause insulin resistance for 12 to 48 hours. So in other words, when we sleep, there's other things going on in our body too. And a lot of diabetics, when they're on a diabetic diet, they'll give them a little snack at night before bedtime, about an hour before bedtime, so they hopefully their blood sugar won't drop during the night. And then we have diabetic ketoacidosis, or what you're going to hear called DKA. If you see DKA on a patient's chart, you know they've got diabetes. As the patho of untreated type 1 diabetes continues, the insulin deficit causes fat stores to break down. The result is continued hyperglycemia and mobilization of fatty acids with a subsequent ketosis. Diabetic ketoacidosis, or DKA, develops when there is an absolute deficiency of insulin, and an increase in the insulin counter-regulatory hormones. Glucose production by the liver increases, peripheral glucose use decreases, fat mobilization increases, and ketogenesis, or ketone formation, is stimulated. Increased glucagon levels activate the glucogenic and ketogenic pathways in the liver. In the presence of insulin deficiency, hepatic overproduction of beta hydroxybutyrate and acetoacetic acid, or ketone bodies, causes increased ketone concentrations and increased release of free fatty acids. Because of the loss of bicarbonate, which occurs when the ketone is formed, bicarbonate buffering does not occur and a metabolic acidosis, or DKA, occurs. Depression of the central nervous system from the accumulation of ketones and the resulting acidosis may cause coma and death if left untreated. DKA may occur in an individual with diagnosed diabetes when energy requirements increase during physical or emotional stress. Stress states initiate the release of gluconeogenic hormones, resulting in the formation of carbohydrates from protein or fat. The individual who is sick, who has an infection, or who decreases or omits insulin doses is at great risk for developing DKA. And so here's 4 things that you will see. Hyperosmolarity from hyperglycemia and dehydration. So in other words, your kidneys are going to show that you're dehydrated. Metabolic acidosis from an accumulation of ketones. And so if you're acidotic, that's not good. I mean, you can become comatose and again die from that. extracellular volume depletion from osmotic diuresis, so we're losing fluid, and electrolyte imbalances because of this fluid loss. When we lose fluid, we lose potassium and we lose sodium, and we need these electrolytes to help our heart and our muscles and all of that work properly. Manifestations of DKA result from severe dehydration and acidosis. DKA requires immediate medical attention. Admission to the hospital is appropriate when the blood sugar is greater than 250 with a decreased pH or acidosis and ketones in the urine. If the patient is alert and conscious, fluids may be replaced orally. In the first 12 hours of treatments, adults usually require 8 to 10 liters of fluid to replace losses from polyuria and vomiting. Alterations in level of consciousness, vomiting, and acidosis are common, necessitating IV fluid replacement. So you may see normal saline, which is 0.9%, at a rate of 500 to 1,000 milliliters an hour. Rapid infusion, because we've got to get some fluids back into the patient. But you have to be careful, make sure they're not a heart patient, and they'll go into congestive heart failure too with that high rate. After 2 to 3 hours, or when the blood pressure is returning to normal, you want to administer 0.45% saline, which is what we call half normal saline, at 200 to 500 milliliters per hour for several more hours. When the blood glucose level reaches 250, dextrose is added to prevent rapid decreases. Hypoglycemia could result in fatal cerebral edema. So you got to replace according to the time frame, and don't do it too rapidly because you could kind of throw the body in a state of shock. Regular insulin is used in the treatment of DKA. It may be given by various routes, and we're going to talk about the routes depending on the severity. Mild ketosis may be treated with sub-Q insulin, whereas severe ketosis may require an IV infusion of insulin. And I'm just going to plug this in here. Sometimes we give insulin to get patients' potassium levels down as well, because the potassium will bind to the insulin molecule and it'll get it out of the system. That's just a tidbit of information for you. The electrolyte imbalance of primary concern with DKA is depleted body stores of potassium. At first, serum potassium levels may be normal, but they decrease during treatment because, like I said, insulin binds with potassium and it'll drop it. In DKA, the body loses potassium from increased urinary output, acidosis, catabolic state, vomiting, and or diarrhea. So potassium is begun early in the treatment, usually by adding potassium to the rehydration fluids. Replacement is essential for preventing cardiac dysrhythmias secondary to hypokalemia, which is low potassium. Cardiac rhythms and potassium levels must be monitored every 2 to 4 hours. I can't stress that enough. Anybody that's getting potassium should be on a monitor. And so now we get to hypoglycemia. So we talked about hyper, which is elevated blood sugar. Now we're going to talk about low blood sugar, hypoglycemia. Cool and clammy, need some candy. It's common in individuals with type 1, occasionally occurs in individuals with type 2 who are treated with oral hypoglycemic agents. This condition often is called insulin shock, insulin reaction, or the lows in patients with type 1. Hypoglycemia results primarily from a mismatch between insulin intake, an error in insulin dose, physical activity, carbohydrate availability, omitting a meal, the intake of alcohol and drugs such as chlorphenicol, sodium warfarin or Coumadin, your monoamine oxidase inhibitors or MOAI, probenecid, salicylates like aspirins, and sulfonamides. All of these drugs can cause hypoglycemia. The manifestations of hypoglycemia result from a compensatory autonomic nervous system response and from impaired cerebral function caused by a decrease in the glucose available for use by the brain. The manifestations vary in older adults. Look at table 12-3 for that. The onset is sudden, and blood glucose usually is less than 45 to 60, and that has to be treated. When you have a patient with their blood sugar below 70, look at your doctor's orders and see what the doctor ordered. So individuals who have type 1 diabetes for 4 or 5 years fail to secrete glucogen in response to decreased blood glucose. Excuse me. I'm sorry, excuse me. This compensatory response can become absent or blunted, and the individual then develops a syndrome called hypoglycemia unawareness. The individual experiencing this does not experience symptoms of hypoglycemia, even though it is present. So they still are hypoglycemic, they're not feeling the symptoms yet. Because treatment is not initiated because of the absence of symptoms, the individual is less likely to have episodes of severe hypoglycemia. When mild hypoglycemia occurs, immediate treatment is necessary. Individuals experiencing hypoglycemia should take approximately 15 grams of a rapid-acting sugar, when the physician may order glucagon for that. And if you can't take it by mouth, they'll order it IV. The amount of sugar is found, for example, in 3 glucose tablets, half a cup of fruit juice or regular soda, 8 ounces skim milk, 5 lifesavers, 3 large marshmallows, or 3 tablespoons of sugar and honey. Sugar should not be added to the fruit because fruits have natural sugars. Adding sugar to the fruit already in the juice could cause a rapid rise in blood glucose, and you don't want to jump from hypo to hyperglycemia. If the manifestations continue, the 15-15 rule should be followed. Wait 15 minutes, monitor blood glucose, and if the blood glucose is low, eat another 15 grams of carbohydrate. This procedure can be repeated until the blood glucose levels return to normal. Individuals with diabetes should have some source of carbohydrate readily available at all times. And like I said, the physician will have something ordered for that particular patient. I'll go back to my last slide so we can finish. Well, it won't let me go back, but that's okay. So remember the 15-15 rule, but if you keep having to do it for so many 15 minutes, you need to contact your physician as well. If hypoglycemia occurs more than 2 or 3 times a week, the individual's diabetes management plan should be adjusted because it's not working. Patients with diabetes who have severe hypoglycemia are often hospitalized, and here's the criteria. Blood glucose is less than 50 milligrams per deciliter, and the prompt treatment of hypoglycemia has not resulted in improper recovery. The patient is having coma, seizures, or altered behavior. It's been treated, but a responsible adult cannot be with the patient for the following 12 hours because it can happen again. And the hypoglycemia was caused by a sulfonylurea drug, so they need to be monitored and that medication changed. If the patient is conscious and alert, 10 to 15 grams of an oral carbohydrate may be given. If the patient has an altered level of consciousness, administer parenteral glucose or glucagon. And I said that a while ago. It can be given IV. Give 20 to 50 mils of a 35 to 50% glucose, usually at a rapid rate of 10 milliliters over 1 minute by IV push. This is the most rapid method of increasing blood glucose levels. Then start a continuous IV infusion of glucose, 10 to 20% at 15 to 200 milliliters per hour. Glucagon is an anti-hypoglycemic agent. It raises the blood glucose by prompting the conversion of hepatic glucagon to glucose. It is used in severe insulin-induced hypoglycemia, and its recommended dose of 1 milligram by subcutaneous, intramuscular, or IV route. Glucagon has a short period of action, and oral or IV carbohydrates should be administered following the glucagon to prevent a reoccurrence of the hypoglycemia. If the patient has been unconscious, glucagon may cause vomiting when consciousness returns. So you have a very detailed on page 814 of what you are supposed to do when your patient is experiencing hypoglycemia. I would read this section, definitely know this. You need to know the signs and symptoms of hypoglycemia. Again, they're cool, clammy, lethargic, comatose, altered mental status. Their skin color often changes, and they may just say, I feel lightheaded, I feel woozy, I don't feel good. And a lot of diabetics can tell you when their sugar's low because they know what it feels like. So what are some chronic complications? Some of these are diabetic neuropathy, and you have stage 1, 2, and 3 there. And this, I'm sorry, diabetic retinopathy. I'm jumping ahead of myself. And this is where it affects the retina of the eye. And to keep this from being too long, I'm just going to, tell you to read over this section here, okay? And then you can have diabetic nephropathy, and this is where it affects the kidneys by the presence of albumin in the urine, hypertension, edema, because if our kidneys aren't getting rid of the fluid and they're damaged from diabetes, our blood pressure is going to go up. Make sure that you read over diabetic retinopathy and diabetic nephropathy. One affects the eye, one affects the kidneys. And then there's diabetic neuropathy, and I want to spend just a few moments here because this is one that you see a lot with diabetes. You have peripheral and visceral neuropathies, or disorders of the peripheral nerves and the autonomic nervous system, and this is called diabetic neuropathies. The etiology is diabetic neuropathies include thickening of the walls of the blood vessels that supply the nerves. It causes a decrease in nutrients, and it causes a delay in the stimulation of the nerves. So you may have pain, tingling, sensation, according to the different types of damage that you have. A lot of people have restless leg syndrome because of this. You just have this pain that won't go away because the blood supply is decreased from the thickening of the vessels, and we know that our oxygen is carried on the hemoglobin molecule in the red blood cell, and so we have decreased oxygen to our lower extremities, and it causes pain. Make sure that you read these three. Diabetic retinopathy is the eye, diabetic nephropathy is affecting the kidneys, and diabetic neuropathy affects our peripheral and our circulation in our lower extremities. Make sure you read over that, okay? And then some other things that it affects: coronary artery disease, hypertension. I want you to read over these as well. It can lead to stroke, peripheral vascular disease. It can affect our ability to have enough circulating volume, which can lead to what I said earlier, gangrene, and that's the most common cause of the amputations. So as the vessels narrow and the blood supply is cut off, the tissue starts to die and it becomes black and necrotic, and it can become infected, and it emanates this terrible odor. If you've ever smelled gangrene, you know exactly that it's gangrene. And then it makes the patient very susceptible to infections in that area. You have alterations in mood because it does affect our brain. And, when we're not getting enough circulation to our brain, we're not getting enough oxygen again. And then it talked about using antidepressant medications, stress management programs, and then just, trying to manage your diabetes better. You're also very susceptible to infections because the higher the sugar content, the more bacteria grows. And so you really want to make sure that, that you're bathing every day, that you are cleaning between your toes and making sure that it's dry. Um, you don't want to put lotion between your toes because that can hold moisture and cause bacteria, but you want to make sure that your skin's not dry and cracked as well. We're going to talk a little bit about that. And it can also cause periodontal disease, which can lead to heart problems. And you want to make sure that you educate your patient, brush your teeth at least twice a day, floss at their meals, go see the dentist, get your teeth cleaned if you can, just good daily hygiene. Then on page 817, it talks about complication of the feet. Because of the circulation, we our blood supply is cut off, so we often see a lot of amputations below the knee. It says the blood vessels most often affected are located below the knee. Blockages form in large, medium, and the small vessels. And so the blood flow is cut off. And so the tissues, it starts to die in that area, and it's very painful. It says, despite the many potential sources of foot trauma in the individual with diabetes, the most common are cracks and fissures caused by dry skin or infections such as athlete's foot, blisters by poorly fitting shoes, pressure from stockings or socks, ingrown toenails. These people need to go see a podiatrist. We do not listen to me. We do not cut diabetic toenails. You may have learned that in fundamentals. We do not cut their toenails. And when you do fingernail care, you file the nails straight across. Don't ever cut down into the quick because it can cause a skin ulcer. Look on page, let me see, where is it? And we're going to talk about this under the nursing implications, care of the feet. Look on page skin integrity on page 832. And there's actually a whole section there on patient teaching on foot care. And so I want you to make sure that you are going over that very thoroughly, okay? And we're going to talk about that. Collaboration, keep the blood glucose levels near normal, reduces the risk of complications by 60%. So how do we do that? With medications, our diet, and exercise. And so that we want to make sure that we're eating 3 times a day, that we are getting the proper snacks, low sugar intake, watch, like instead of eating white rice, eat brown rice, wheat bread instead of white bread, because all that breaks down to sugar in the body. Be careful with bananas. Bananas have a high sugar content, so the patient may only be able to have a half a banana a day. Lots of fruits and vegetables, but fruits that are low in sugar. Lots of vegetables, skinless meats, that are grilled or baked or broiled, not frying. We know that any of you that are from the South, I'm telling you, the diet down here is very high in fat content, and we have a lot of problems with diabetes in this area as well. Look at diagnostic test on page 817. You have the hemoglobin A1C, and if it's equal to or greater than 6.5%, then you may be deemed as having diabetes. Symptoms of diabetes plus the glucose concentration of greater than 200, fasting plasma glucose greater than 126, and the 2-hour plasma glucose greater than 200 during an oral glucose tolerance test. So when you do the glucose tolerance test, they give you this high intake of a sugar drink And if your sugar is going to go up for sure. But if it doesn't come back down within the designated time frame, if it stays up, then you're more than likely having issues with diabetes. When the criteria are used, the following levels are used. Normal glucose equals 2 hours um, uh, uh, for the plasma glucose less than 140. Impaired glucose tolerance test equals 2 hours greater than 140, and diagnosis of diabetes equals 2 hours of the plasma glucose greater than 200 if it's over 2 hours. And you have to do it a couple of times to confirm it. Then some of the other tests that we look on page 818, fasting blood glucose. You can do this, they have to draw blood to do a fasting. And you see here they list a normal range of 70 to 110. Again, different in facilities use different ranges, but for testing purposes, we will follow our textbook of 70 to 110. The hemoglobin A1C, and it determines the average of blood glucose level over approximately the previous 2 to 3 months. When glucose is elevated or control of glucose is erratic, glucose attaches to the hemoglobin molecule and remains attached there for life of the hemoglobin, which is about 120 days. The normal level depends on the test done, but values greater than 6.5 are considered elevated. So you don't have to be fasting for an A1C test either, but you do for a blood glucose test. Urine, they're going to look for the ketones, and they give you the ranges there. Urine test for albumin, which they'll do a 24-hour urine test to see what your creatinine clearance is from your kidneys. They'll also check your cholesterol and triglycerides, and they want your the ADA recommends treatment goals to lower low-density lipoprotein cholesterol to less than 100 milligrams per deciliter, raise high-density lipoprotein HDL cholesterol to more than 40 milligrams per deciliter in men and more than 50 in women, and lower triglycerides to less than 150. I would know that. You need to know that. Okay? You need to know this information on page 818. All right, so how do we monitor blood glucose? We have multiple ways. You can do urine testing for glucose, and that's when you use the little ketone sticks. You can do self-monitoring of blood glucose where you prick your finger. That's called a finger stick blood sugar. And you can use a machine like you see on page 819, and you will see a lot of this done in the hospital. Make sure you read over this. It's very self-explanatory, and you probably should have already had some of this in fundamentals, so this should be a repeat for you for checking the finger stick blood sugar. Self-monitoring, it allows the person to do it themselves. Sometimes they do it 3 and 4 times a day, sometimes once a day. It all depends on what the physician orders. And you have to teach them how to use the machine, how to properly, clean their finger with alcohol, then dry it, then stick it, put it in the machine, read it. Make sure that you don't get the sample that you don't stick when it's still wet with alcohol. What I do is I clean it with alcohol, then I wipe it with a dry 2x2, which is sterile, and then I get my reading. Okay, so just remember that. Factors that affect glucose meter performance. This is hematocrit. Patients with higher hematocrit values test falsely low in blood glucose. Patients with lower hematocrit will have high glucose. Medications can cause changes in your glucose levels. And one of the medications, and I always want you to remember this, and students, every time I ask them a year later, they're like, I don't know that. Well, I'm telling you right now, if you're a patient and you're on steroids, your blood sugar is going to go up whether you're a diabetic or not. Steroids cause your blood sugar to increase. So patients that are on steroids, especially IV steroids in the hospital, they need to have their blood sugar checked. Don't forget that, okay? Um, So let's talk about some insulins, and you will get more of this when you get into pharmacology. Insulin is what we give to bring the glucose down, but there are dangers with insulin. It can drop it too fast. So as a nurse, when you administer insulin, you need to monitor and assess that patient for signs of hypoglycemia. It can only be given by sub-Q injection or IV. It cannot be given by the oral route because the gastric juices in the stomach or the GI tract kill the effect of it. And that's why we can't take it by mouth. So it has to be sub-Q or IV given. Look on page 820, and it lists your rapid acting, which means it's going to act fast. So you have Lispro, Aspart, and glucosine. Short acting is regular insulin. So sometimes you may have to give regular insulin with your routine insulin, and you have to know how to mix it and draw it up properly, and you should have had that in fundamentals. Intermediate acting is your MPH, and you see that one given a lot. Long acting is Lantus or Levemir, but I'm telling you, don't give any insulin if their sugar is not within the normal range. I don't care when it acts, it is still insulin, and it's going to bring their sugar down at some point. So if a patient's got a blood sugar of 53, you are going to treat that low blood sugar and not worry about the insulin right then. You're going to have to treat it, monitor it. You may give the insulin later. Please, please remember that. And then you have your Humalog 50-50, 75-25, 70-30, Novolog, Humulin, and those are the most common, 70-30. Please make sure you look at that on page 820. And you will see this again when you get to pharmacology, okay? But I do want you to have a general knowledge of this information on the slide here. It said that with the Lispro Humalog, administer 15 minutes before meals. You want to make sure that with your patient that when you administer insulin, they're getting ready to eat because they need that food to help balance the insulin that you have given them, okay? Some of the concerns, look on page 820. It says Glargine, Lantus, and Dedamir, Levemir are clear, unlike other intermediate or long-acting insulins. Do not mistake these for regular insulins because regular insulin is clear as well. Do not mix them with other insulins. Do not inject them intravenously, only sub-Q. Lantus and Levemir. Lantus and Levemir. Do not mistake. They're clear. Do not mix them with other insulins and do not inject them IV. Only sub-Q only. Only sub-Q. Okay. Look, if it says for the Lantus, it's not recommended for use in pregnancy, should not mix, cannot use in the IV pump. Okay. Insulin concentrations are usually 100 units per milliliter or 500 units. And so when you draw it up, you're going to draw it up in units. And if you're giving a rapid acting insulin, you know, like I said, what does it say? It's rapid acting. So it's going to act very, very fast, and it's going to bring the blood sugar down fast. So you need to monitor the patient as you're doing that. All insulins given parenterally, regular insulin, sub-Q or IV, all other insulins subcutaneous, regular insulin, sub-Q or IV. And remember, look it up. If you've got to mix insulins, make sure you look it up before you mix them. You have to check compatibility. Regular or rapid acting used in continuous subcutaneous insulin infusions. So sometimes people are on an insulin pump because their sugar's so high and they're trying to get it down. Maintain normal blood glucose levels during the hospitalization decreases the risk of post-op infections, and it shortens the stay. So, you know, if your sugar's really, really high, the IV route is going to be the preferred method. because everybody's body absorbs differently, and it does depend on the amount of adipose tissue. It talks about insulin pumps and special injection products. Make sure that you read over that as well. Um, I really want you, and I'm just trying to keep this presentation from I'm already at an hour, but on page 818, 819 to 821 talks about these different types of insulins. And you just need to sit down and read through this very thoroughly before you come to class, okay? And read over this chart as well. Because again, I could spend a whole another hour just talking about the insulins, and you're going to get this more of this in pharmacology as well. But remember, regular insulin is given to get the sugar down rapidly. It's rapid acting. And so this little chart on 820 is a very good guide to help you remember those things. It can be kept at room temperature. Regular insulin doesn't require any mixing. If it is regular insulin, if it's cloudy or discolored, get rid of it. Other types require gently rolling. So if it's cloudy, you want to roll it back and forth in your hand. You don't want to rigorously shake it, and an air bubble can displace some of the particles in it. The injection, look on page 821, you see the injection sites. The most common are in the abdomen, about 1 inch below the belly button. You want to give it in as much of the fat tissue or adipose tissue as you can find, and on the back of the arm. And remember, when you stick it in and inject the medicine, don't pull it out so quickly. If you pull it out too quickly, the insulin will leak back out of the skin. So when you put the injection in, you put it in. I was always told to put it in and count to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then pull it out. That's what I was always trained to do. It can be done in any body area where there's sub-Q tissue. So you see the little diagram here, and there's one on 821 as well. Certain body sites are recommended, such as the abdomen and the back of the arm. A lot of people like to have it on the back of their arm. Do not massage after you give the injection. Do not inject into an area to be exercised or to which heat will be applied. Make sure that insulins are refrigerated, and they have to be let me take that back. All insulins don't have to be refrigerated. Okay, you have to read what it says on there about the insulin. It talks about lipodystrophy and or lipoatrophy, and this may result from using the same site repeatedly. So what are we supposed to do? We rotate sites. If I give it on the right abdomen today, the next injection goes on the left abdomen. Then I may go to the right arm and go to the left arm if I can use the arm. People who have had mastectomies, you don't need to give it in that arm, or if they have something else going on with that arm. Aspirin therapy once a day to help with counteract the effects of the issues with circulation. And here's some of the contraindications with aspirin. And I'm just going to say this right now. I'm just going to say this. Aspirin is also an antiplatelet, or that it's an antipyretic for fever. It's an analgesic for pain, but it's also an antiplatelet. That's what anticoagulant therapy means. Before you give aspirin, you need to go to the lab tab on your chart and make sure the platelet level is not too low. If it's too low, you have to hold the aspirin. And we will work with you on that. I'm a stickler about checking labs before we give medicines. You want to use an enteric-coated aspirin to help keep it from upsetting the stomach so much. And then nutrition management. You want to maintain as near normal blood sugar as you can, achieve optimal levels, provide adequate calories, maintain an appropriate weight, prevent and treat the acute complications of insulin-treated diabetes, short-term illnesses, exercise-related problems, or long-term complications. Improve overall overall health through nutrition. And you may want to look at my plate. So uh, that is one of the things that my plate, and I have that on another presentation. Um, but my plate shows you how many grains and fruits and vegetables and breads and stuff like that you should have. Nutrition management should focus on making sure that you're getting the right amount of carbohydrates. We do need to have some. We've got to have energy, grains, fruits, vegetables, milk, and usually skim milk, some dairy products, as long as we don't recommend whole milk. Simple sugars versus complex carbohydrates, anything that cake, donuts, junk food, anything with a lot of bread, a lot of cheese, fast foods, processed foods, they're high in fats and sugars. You want to get, skim milk, again, fruits and vegetables. Stay away from fast food and stuff like that. Then your chapter talked about the glycemic index. And when we're looking at that, the glycemic index is the rate at which a food raises blood glucose and thus insulin. Proponents of low carbohydrate diets use glycemic index as the scientific foundation for decreasing intake of foods with a high glycemic index. So they're looking at the foods that raise your blood sugar, and they tell you to stay away from them. And what might raise mine might not raise yours. I had a diabetic patient one time. Every time I went to see that patient, I was working in home health, and the patient loved bananas. He would eat 3 and 4 a day, and his sugar would be 400 every time I'd go. And I'm like, how many bananas are you eating? I only eat about 4. I'm like, you need a half a banana a day. He didn't like that too much, but that's what he needed to do. And again, this really it really messes with you psychosocially. Yeah. Protein intake. We really need to get our protein. And here's of course, sources of protein: our meats and nuts and grains. Dietary fats, saturated fats, polyunsaturated fats, canola oil, things like that are very good. Olive oil is very good for cooking and those type of things. We need to be careful, not to use too much. I use olive oil a lot to, season vegetables and things. And so just make sure that you're getting the kind that is, low in fats and saturated fats. You want unsaturated fats oils. Again, we want fresh vegetables, fruits and vegetables, grains, that kind of thing. Sodium, we want to monitor our intake of sodium, because if our circulatory system's affected, then our blood pressure could be up. And then salt helps us to retain fluid, and so makes our blood pressure go up anymore. Processed foods and table salt. Foods naturally have sodium in them. You can use salt substitutes, but be careful to make sure and teach the patient to look what the potassium level is in the salt substitutes. And then your sugars, refined sugars. You need to be careful. It's so hard though. We love sweets, and it's just hard to do without them. Alcohol consumption. Drinking alcohol beverages is not encouraged, neither is totally prohibited with the patient with diabetes. It may potentiate the hypoglycemic effects of insulin and oral agents. The ADA recommends that men with diabetes consume no more than 2 drinks per day, and that women with diabetes consume no more than 1 drink per day. The signs of intoxication and hypoglycemia are similar, so the individual with type 1 diabetes is at increased risk for an insulin reaction. Liquor, sweet wines, wine coolers, sweet mixes have a large amount of carbs in them. Light beer is recommended. Alcohol should be consumed with meals and included in the daily food intake. The alcohol is substituted for fat in the circulating diet. A drink with 1.5 ounces of alcohol is equivalent to 2 fat exchanges. It is better to consume alcohol with your food because it helps process it and break it down, and doesn't cause as much liver damage as well. When you're planning meals, look what you can exchange. What carbohydrate can I exchange for this sugar? Okay, and uh, there are all kinds of plans out there that you can pull up and go over. There's um, the ADA diet, and it'll say low carbs, low sugars, and you can pull those diets up and give the patient a printout of that. Sick day management: when the individual with diabetes is sick or has surgery, blood glucose levels increase even though food intake decreases. The individual often mistakenly alters or omits the insulin dose, causing further problems. The guidelines for dietary management during illness focus on preventing dehydration and promoting nutrition for promoting recovery. So you want to monitor the blood glucose levels at least 4 times a day. Check for ketones that are greater than 240. Continuing to take the usual insulin dose or oral hypoglycemic agent, sipping 8 to 12 ounces of fluid each hour, because we know a lot of times when we're sick, we don't want to eat or drink or maybe throwing up. Substituting easily digestible liquids and foods as solids if not tolerated. Some gelatins or fruit juice or a popsicle or some sherbet. You got to have something when you're sick. You got to have a little bit of sugar in your system. And then your book talks about exercise, and we really need to exercise because it helps us, burn up these calories that we've consumed, and that helps bring down our glucose levels. Sedentary lifestyle, those glucose levels are just kind of sitting there, and your body's not using them for energy. Just make sure you read over that, okay? And then it talks about surgery. I just want you to read over that. I probably won't ask you any questions about surgery, but there are just different things: infected wounds, transplants of these isolate of Langerhans in the pancreas. Okay, so just read over that. Okay, and then it goes to lifespan considerations, and it talks about diabetes in children. And it's very hard um, to work with children because they don't want to feel different. They don't want to be deemed different. And they know that they're different. They can't eat what you eat. They may have to take an apple for lunch, and some lean meats, and some carrot sticks and celery sticks, and drink skim milk while you're over here eating the cafeteria food, and they can't do that. Again, in children and adolescents, hyperglycemia, increased thirst, hunger, urination, and you may have to teach this to the families. Fatigue, blurred vision, weight loss, usually acute, requires emergency interventions if they're hyperglycemic. You see a lot of DKA in your younger population with diabetes. And we want to get to a state of euglycemia, which is a normal glucose level, euglycemia. And so you want to, bring in a dietitian, a certified diabetes educator, and show them the foods that they can eat. Kids love chicken nuggets, and they love macaroni and cheese. They love pizza. It's not that they can't have these, they just can't eat a half a pizza. You might can have one slice of pizza with some vegetables and stuff. And it's very hard with any age because most people don't like vegetables. I'm different. I love vegetables. I could eat them all day long. With children, here are your diagnostic levels that determines if they are diabetic. Glucose monitoring, you may have to do it more frequent in children, especially younger children, because they may not be able to tell you how they're feeling. You have to really monitor them and watch their behavior. And when diabetes occurs in children, it's called juvenile diabetes, and they sometimes they use that term, sometimes they don't use that term. Children and adolescents, again, the daily dose depends on their weight, where they are, their eating habits. You may have to teach the parents or maybe it's just a 15-year-old and they don't want their parents to do it. You got to teach them how to do it. And one of the biggest things is soft drinks. People really love their soft drinks, and so it's very hard to get them to give that up and to teach them, approaches that will help them. Look on page 826. It talks about 10 tips for better glucose control in children. Be persistent. Be involved in the day-to-day. Provide structure. Make sure they get 3 meals a day. They get their snacks and they're getting stuff that they like, but it's within the ADA diets, not all those high sugars and everything. And you can buy stuff that's doesn't have sugars in it. Keep accurate records. That you want to check their sugar 2 to 3 to 4 times a day. It needs to be recorded. Think like a pancreas. I really like that one. Understand the physiology of what's going on with the pancreas and explain it to the child. Show them a picture of it. Demand quality from your healthcare team. Network with other families, support groups. If it's broken, fix it. Involve the child. Don't just let you do everything. Let them learn how to do this kind of stuff. And let kids be kids. It talked about in your chapter about children playing sports. Let them play sports unless they are truly that compromised with their diabetes. Let them play sports. Okay. Um, it talked about diabetic ketoacidosis. Again, it's very life-threatening, and it's basically the same information that we've already covered in this chapter. Again, the same thing with alcohol use. We do know that younger teenagers are indulging more and more into those type of substances. And then you have table 12-9. It talks about screening and treatment recommendations for children. And this is just some recommendation. If you were a nurse teaching a diabetic child, you may want to pull something like this and go over it with the family. Diabetes, again, can have, long-term effects. And one of the biggest issues, again, with children is diet and getting them to exercise, monitoring their blood sugar, eating right, and just letting you know. Children won't talk to their parents, letting you know when they are feeling bad. And so just read through that section, okay, because it says a lot of what we already covered with the adult. Pregnant women, this is called gestational diabetes. And so if you are diabetic, of course, you're going to be monitored very closely. But if you start exhibiting symptoms of elevated blood sugar and excess weight gain, they're going to come in and do some testing on you. One of the things with gestational diabetes is because of the sugar levels are higher, you will have a large baby. Yeah, usually 9 to 10 pound babies at 9 months. So with pregnant women, you want to have preconception counseling. You want to have glycemic control, so to avoid these risks of spontaneous abortions, congenital anomalies, preeclampsia, fetal demise, macrosomia, that's a large baby, and the baby itself can experience hypoglycemia if you're diabetic after they are born. So, of course, the target A1C is less than 6.5. But you may already be diabetic and you want to get pregnant as well. Again, in the older adult, we've already talked a lot about the older adult. Again, here's the same list we've already covered earlier in the chapter. And we talked about depression and, the same with the adult, with their child. They, getting them to eat the right kind of diet, teaching them how to monitor their blood sugar. Maybe they don't read well. Maybe they can't see well. Maybe they don't comprehend instructions. Is there someone available to show them how to check their sugar? And another thing with that is people don't like sticking their finger every day. So there's all this new technology, and you've got the one mounted on your body, and you can put your cell phone up to it. I recently had a patient like that in the hospital, and he could check his sugar anytime on him. The nursing process. So we really want to, Look at their illness. Assessment, planning, and implementation is different for each patient. I may be working with a teenager versus a 70-year-old. You want to focus on survival skills. The individual learns basic knowledge and skills in diabetes. Again, you may have to do a lot of teaching. Teach them what are the signs and symptoms of hypoglycemia. Remember, if the blood sugar's low, I feel bad, cool and clammy, I need some candy. If my sugar's high, hot and dry, too high, I may have a fruity breath to my odor if my sugar's too high. I may have a yeast infection. I just may feel bad, tired. It talked about the malaise and the fatigue. Or I may lose consciousness. So don't forget those things. Make sure you read that section well. So when we observe and interview, we ask questions regarding any family history of diabetes, hypertension, cardiovascular problems, dizziness, numbness in the hands or feet, any changes in vision, speech, pain when walking, frequent voiding, changes in weight, appetite, and do you stay hungry all the time? Are you constantly hungry? Physical exam, you want to assess the skin, assess the cranial nerves, their sensory ability to hot and cold. Look at the peripheral pulses and close inspection of the skin, the mucous membranes, hair loss, rashes, itching, vaginal discharge, all of those types of things. Physical assessment, again, here are some of the things that I just spoke of, and same thing here. And so here your nursing diagnoses, one of the biggest ones going to be knowledge deficient, because most people are like, I didn't know I was a diabetic. No wonder I've been feeling so bad. And so they just have lack of knowledge. Your plan is to describe how to administer meds and respond to the side effects. Because remember, these meds are going to bring your glucose levels down and you may experience hypoglycemia. So you need to teach them which meds will do that, which meds elevate my blood sugar. Again, steroids, and there's others. Demonstrate meal planning, bring in a consultant, demonstrate proper foot care, demonstrate proper procedure for monitoring the blood sugar, teach them how to do their finger stick blood sugar, and reducing risk of infection. Try to not get any sores or anything on them. Implementation, you want to give them and the family education about diabetes, about exercise, monitoring their blood levels or their blood glucose, their medicines, and how to monitor their skin, how to manage that sick day when you just can't get your sugar under control. Teaching about diet, hygiene. You need to take a bath every day. You need to dry your skin well. You need to use lotion, but you don't want to use lotion in between your toes because, again, it holds moisture and it will cause bacteria to grow. And all that, it talks about all of that on page 832 and 833 and 834. Maintain safety. You don't want to fall and get hurt. Get them some help with their psychosocial issues. Are they just emotionally can't deal with this? I have a sister and three brothers that have diabetes. It runs very heavily in my family. And my sister, when she first found out and she was just trying to stick to the diet and she was so hungry and just wanted something sweet, she had a breakdown. She just all she could do was cry. She said, I just can't do this. It's so hard to do this. And so dealing with diabetes is a daily struggle. Because look at all you have to do. I got to monitor my skin. I got to monitor my hygiene. I got to monitor my dental. I got to worry about yeast infections. That's that candida. I got to worry about side effects of medicines. Is the insulin going to drop my sugar? I can't eat this. I can't eat that. It's difficult. It is difficult. And then it talked about coping. And again, one thing I really want you to look at on page 833 is that foot care. Never go barefoot. Wear slippers. Do not use commercial corn pads or anything if you've got corns and stuff on your feet. Don't cut them off with a knife. Some people cut the corns and calluses off their feet with a knife. You're going to have sores there and then you're going to get infected. Do not use heating pads, hot water bottles, or ice packs on the feet. If they become cold at night, put some socks on. Do not allow the feet to become sunburned. Do not put tape on the feet. Do not sit with the legs crossed at the knees or ankles. Your shoes should allow some room. They shouldn't be so tight that they can't breathe, because it holds moisture and it causes rubbing up against the skin. It'll cause the skin to break down. Do not wear open-toe shoes, sandals, high heels, or thongs. So in other words, people say, oh my goodness, I got to wear those ugly diabetic shoes. You know, that is hard, because diabetic shoes are not stylish. They're practical, and that's very hard to get past that. Buy shoes late in the afternoon when the feet are their largest, so you know that you're getting a shoe that's got more room in it. Shoes made of natural fibers, leather or canvas, allow perspiration to escape. Check the soles before each wearing for foreign objects. Socks or stockings may be wool or cotton. Do not wear garters, knee stockings, anything that cuts off the circulation. Wear insulated boots in the winter. Check the feet daily for red areas, cuts, blisters, corns, calluses. Check between the toes for cracks or redness. Check the skin of the feet for dry or damp areas. Dry them well. Pat dry the skin. Don't rub it, because you'll break it. If you're unable to inspect the feet daily, let someone else do it. Cut the toenails after washing when they are softer. And again, nurses should not be cutting patients' toenails. We shouldn't be doing that. They really need to go to the podiatrist. Cut the nails straight across with clippers and file them down with an emery board. Do not use razor blades to the toenails. Some people do that. They cut their toenails with a knife. You'd be surprised. If you're unable to see your feet well or to reach them easily, have someone trim them for you, but you need to go to the podiatrist. You should not be cutting toenails. And then, of course, our evaluation is we want the patient to have normal blood sugar and be safe, free of skin injury, infection, maintain their diet, know how to check their sugar, know what exercises they should do, know when to take their insulin, how to take their insulin, and look for signs and symptoms of hypoglycemia. And I think that's our